I wanted to start today with a conversation I had with Christian up in Naples about very difficult patients. So I'm not going to throw you under the bus, Christian, but I'm going to throw you under the bus.
Throw me. Throw me.
Share us the story about just the 5-second Cliff Note version of the patient that you had. We've all had this patient.
Yeah, it was that patient that, yeah, I mean, you just look at them and they go, You're not even doing anything. You put the mirror in their mouth and they act like you punched them in the face. I mean, it's illogical. I don't know, no matter what you do, how gentle you are, it's like you're stabbing them in the mouth with a needle every single time. And how to handle that. Like, I did a crown prep on him 2.5 weeks ago, and it took me 3 hours because he literally the whole appointment took 3 hours because he couldn't get through it every little bit. It was ridiculous. And then today, even taking the temp off and putting the crown on, I mean, it just was ridiculous.
So let's take that moment and see if we can build upon it somehow. So annoying patients are annoying. That's a fact. Unfortunately, there are no dental offices that specialize in annoying patients, so we have the luxury of getting to treat them. Yes, they sometimes will cross a line where we can refer them out, make their problem somebody else's problem. What are a few things that we can gain from patients like this that make us better?
Patience.
Yeah, breathing and just
appreciation for those that aren't like that.
Absolutely. So patience, appreciation for the brighter skies.
I think sometimes too we get sort of desensitized a little bit, right, by like doing it all day every day, and then sometimes when there is a patient who's that difficult and terrible, you're like, okay, this is actually truly this hard for this person for whatever reason. Reminds you a little bit.
Yeah.
Yeah, and
I think
you go, Sophia.
I was just gonna say like troubleshooting skills, especially in the beginning.
Troubleshooting to find out what their reason for being so difficult is.
I mean, if they're just doing something and there's now a problem and you think it's going to result in, something not being as good as it could have been, trying to think, okay, what could I do right now that could help me make it better? Because they're going to not stop doing this thing that they're doing.
Yeah, from what I understand from Christian's recanting of this patient, this is something this guy has always been suffering from, just not wanting to have people poke and prod in his mouth. So all very good things. I would say most of these have to do with us looking inside ourselves. So that's one of our safety nets, both personally and professionally, is not trying to blame the person, but not blaming anybody, but instead looking inside and saying, how can I rephrase this in my world to make this less painful for me? I know in dental school, when I reached challenging patients, I wanted those challenging patients because I wanted to be the guy that could fix them. I think there was a little bit of immaturity there that I thought I could actually fix them. But fast forward 15 years and all of a sudden I don't want to see people like that anymore. It's, why is that? So trying to put ourselves back into our, naive minds of like, I bet there was a day when I thought I could somehow connect with this person in a way that made it special for them, so I could be that one person who made that experience be better than the rest. Now, granted, this guy sounds like the kind of person that maybe we're not going to win, but kind of reframing. And Christian, I'm not reframing this as anything other than you provided a really good talking point for us to get started with having that experience with that patient today. But reframing it, how can we show up in the eyes of them to be better, but also how can we show up so that we feel better about the encounter? One of the things that I always try to do is try to understand that their reality is their reality. It's so easy, and I've said it myself, that patient's crazy. Well, the moment we do that, we give up the autonomy to take control of the situation and try to provide a better experience for them. Anybody want to talk about what that might be, where their reality is truly what they're experiencing, therefore we almost need to pretend that everything that they're saying and doing is true? What we're doing is we're comparing them to the normal person. Well, what if they have a hypersensitive nervous system? Does that make them any less right or wrong? Does that change the way we should go about the appointment? Should we be less or more frustrated as a result of that? What are people's thoughts on that? Knowing that that might be their reality, how does that change how we approach the appointment?
I feel like I first try to talk, if I really have put my like little kid gloves on and done everything I can and I still can't get them to be comfortable, I usually talk about anxiety and trying to keep them, have you ever considered Valium? Have you ever considered nitrous oxide? And talk to them a little bit about that. That's personally what the route I take.
Yeah, I think that's where Christian's probably going to go next with the guy.
Yeah.
Using anxiolytics in dentistry is not very well established. So it's very possible that this guy just never even had that opportunity. There are a lot of dentists that don't even dare prescribe a Valium. I'm sure that one or many of these methods would be something to improve the situation with this patient. But I think just making sure we understand that the patient's experiences are real to a certain extent. Obviously, there are people who are pathologically sick in the head. I think this might be one of those people. And if that is the case, what is the right venue for that patient? I don't know the answer to that. There used to be a day when I used to always think that referring a patient to somebody else was me just contributing negativity to the world because I wasn't willing to deal with it myself. In other words, if there is no well-defined venue for that patient, then I should see them, is how I used to think. I think I'm a little more evolved in my mindset of that patient took you how long, Christian, to do what you did? A couple hours, where I should have taken maybe 45 minutes. That's an hour and 15 minutes. You're not helping somebody else. So it's an interesting conversation, something I just wanted to bring to the table. And I think what everybody brought up was great, because it's not so much let's just send the patient to somebody else and make that patient somebody else's problem. I wanted to end with one thing. Those kinds of patients made me the clinician I am today. I'm not saying that I'm anything special. I'm way better than I would have been had I not taken those patients on. It's so easy to be like, I'm just not going to deal with this person. That person makes you better for everybody else. That's not a problem. Zach and I talk about it a lot, call it sharpening our sword. So when you get these patients, remember, they're just sharpening your sword so that you can more efficiently handle the other 99% of your patient population. All right. Anybody want to throw anything else in before we get talking about some cases? Cool. All right, so I'm going to share my screen. Christian, you can be my dedicated, I can see your screen. Because once I switch over, I can't see you anymore.
Yep.
All right.
I see it.
So I just wanted to start with something non-clinical, aside from what we just talked about, and it has to do with HIPAA. I get all kinds of emails from varying sources. I call it keeping my eyes on the profession. So I get these random emails, and I just try to peruse them from time to time, because it gives me, prevents us from being isolated in the world of working on class 2 composites all day. We can kind of get pigeonholed into certain things and lose perspective if we're not taking a look at the bigger picture. I know Zach every once in a while takes a look at the State Dental Board reprimand website to see what people are getting in trouble for. That's super helpful. This is kind of akin to that. Moral of the story, 2 dental practices got in trouble for HIPAA violations having to do with how they were advertising on the website. Things like a patient leaving a nasty complaint or a nasty review, and somebody at the front desk saying something akin to, well, that's not really what happened at your appointment. Here's what actually happened. Or, obviously we have to be super careful in the new digital era in how we convey information and circumstances and leaving a footprint of that anywhere. 10 years ago, I remember hearing a story. It wasn't in Maine, but there was a private investigator who went in the trash of a dental office to try to find unshredded patient records so that they could have a story to publish on the 8 o'clock or 6 o'clock news on this dental office does not properly dispose of their patient information records. And that office ultimately got taken down. So stuff's crazy. You don't hear about this stuff that often. I refuse to hear about it after it happens to me. So I want to hear about it happen to other people and then make decisions accordingly. And that's what this is here. So if we can take away anything from this, if you're sending emails with patient names, never use their full name. Either use their patient ID number or their first initial and last name, or both. All right. So here's our patient Vinny. This is Christian's case. I wanted to use it as an opportunity for us to walk through treatment planning. The arches is kind of where my head's at with this today, and I think we'll get a better sense of what I'm trying to do here. What we're going to do is we're going to use Spear's model on facially generated treatment planning as a way to make this very complicated case easy. So we did a separate video, Christian and I, maybe 6 months ago, on the treatment planning process of this. But let's just kind of walk through. We're not going to go down all of the problems this patient has. I want to focus on how do we resolve this guy's quote unquote deep or collapsed bite. And we'll dive into that. But before we go there, let's ask the question: has this guy lost vertical dimension? Anybody want to chime in on what their thoughts are here? Christian, have we talked about whether Vinny lost vertical dimension? And if so?
I think he has lost some. I think if you look at the posterior teeth as your guide, he's actually maintained his VDO in the posterior. In the anterior, I think you would call it compensatory eruption. I mean, the lowers have come up looking for a contact. The uppers have maybe slightly come down too, looking for that contact. So it's like a pseudo pulse or pseudo collapse bite.
Beautifully stated. So what I typically do is I'll start with the cervical margins of the canines, and I'll draw a line across. And I'll ask myself the question, are the central incisors on that same plane or not? Under normal circumstances, they are. When we have compensatory eruption, oftentimes the bone and the soft tissue will come down with the teeth. What classification, sagittal classification of patients are most likely to have this happen to them? Orthodontic.
Class 2.
Yep.
Class 2.
Yep. Why class 2?
Because their anterior lowers and their upper anteriors are looking for contacts.
Yep. Yeah, so the lower anterior teeth are set back farther than the maxillary teeth. They may have a class 2 situation because they have too much maxillary bone or inadequate mandibular bone, or a combination of the two. Either way, it's an anterior-posterior problem with the lower teeth sit farther back. They're closer to the tongue, closer to the airway, which means they have more room to run superiorly until they hit something or oppose something. And as a result, you see this line. Now this guy's pretty asymmetrical, canted, but if you draw a line from the canines, even the line connecting the cervical margins of the canines on the lower show you that he's had some super eruption of the lower anterior teeth. So the most common perception of a case like this is this patient has lost vertical. Where, Christian, you hit the nail on the head. If you have posterior teeth that are dimensionally more or less in the right arena, then we know we've got vertical here. It's just the interior super erupted at that same vertical until the teeth met. And we're most likely going to see that with a class 2 malocclusion. Class 2 division 1, 1.5. Class 2 div 2, when you have those incisors kicked back, oftentimes they don't erupt as much because there's more interaction between the upper and lower teeth. Does anybody have any questions with this? When we're looking at this particular question of whether they've lost vertical or not, using the concept of compensatory eruption, does this all make sense? Anybody have any insight before we move on to the next part? So this photo here is tempting to guide us down the road of treatment planning. But let me ask you the question, when you do a denture setup, do you put retractors in and then put the upper wax rim in and then adjust the wax rim? No. We let the lip drop. So what's the other piece of information that we utilize to try to ask the question, how do we start planning a case of this complexity?
I think you would start with the incisal edge of 8 and 9, and then given general ranges for age groups. I mean, he's an 81-year-old man, so just trying to assume what should he be displaying for incisal edge position with lip at rest.
So what, you just said it, so what image do we need?
Lip at rest.
Lip at rest. So I think what Frank Spear did, or at least whoever taught him, I would say he popularized the concept of facial aesthetics being very akin to the process that we use for wax rims, for complete dentures. So when we put a wax rim in for a complete denture, we let the patient's lip rest. So obviously we adjust the wax rim until it displays the proper amount of tooth structure that we want to show for that patient's aesthetic, desire, age, function. Christian, what is you started to allude to the fact that there's a range of displays. What would be the kind of the ballpark figures that we look at?
I think if it's, I could be a little bit wrong on this, but if it's like, let's say a 17 to 21-year-old female, I mean, lip at rest, she should be showing maybe 2.5 millimeters of incisal edge position, whereas, an 81-year-old male, given the fact that his elastic tissue is a little bit less tight, I mean, maybe he's showing 1, maybe he's showing 0, maybe he's showing negative 0.5. Like, it all depends on age and what the norms are.
Yeah. There are no right answers. There's only guidances. And I think you put the two ends of the spectrum, the 18-year-old female and the 80-year-old man. I would say there's a bell curve there, 2 to 3 millimeters for that female. And then I would say a guy like this probably 0.5 to 0 would be where most people end up. But this guy's at rest right now, and he's showing 3. So we have a decision to make. Do we tell the lab, please make the wax up at current incisal edge position? Do we shorten it? What other bits of information could we bring in to help us answer this?
How his current speech is.
Yes. Awesome. So one of the things we started doing some time ago, we started having Chantel have them talk. Elena, why is speech important? I mean, it's pretty obvious, but...
Where the incisal edge hits the, oh my goodness. Speaking space? Is that the right terminology?
Yeah, I mean, you just want to see the functionality.
Go ahead and say 33 3 times.
33, 33, 33.
55.
55.
Say it 3 times.
55, 55, 55.
66.
66, 66, 66.
77.
77, 77, 77.
Say Emma 3 times.
Elma, Elma, Elma.
Smile real big. And relax. Relax. And now go ahead and look at the monitor
Now what?
and say 33 3 times.
33, 33,
turn this off.
33.
55.
55, 55, 55.
66.
66, 66, 66.
77.
77, 77, 77.
Say Emma 3 times.
55, 55.
All right, so there's a couple things I want to go over here. One is the rest photo gives us a static position. The full smile photo gives us a static position. And like Elena just articulated, when they speak, we're getting a dynamic sense of how much they display. What are some scenarios that arise that may surprise us in the amount of tooth display that they have during a dynamic process versus the static?
They could have a hypermobile lip.
Bingo. Well done. Yeah, so hypermobile lip. Hypermobile lip is essentially the muscles that they have that exist around the mouth retract the upper lip and lower lip more, thereby displaying the teeth more. There's a really good algorithm, which I think we should probably go over soon, on the gummy smile.
Yeah.
That's not really the topic of conversation, but there's several diagnoses that come out of an algorithm that Spear has done a good job articulating that help us to get a diagnosis of why do patients show more gum tissue than normal. One of them is hypermobile lip. And that was the answer to what I was looking for here, because I think he has a little bit of that, very little. So hypermobile lip would be something that we could determine through the phonetics. We also can gain some appreciation of asymmetrical speech patterns. You know, at the end of the day, I learned a lot more from that video than I did from the static photos that we had looked at initially. I don't think I would have changed my mind in what I think the right answer is for this guy, but we definitely have additional information. Now, what is the question we're asking here? It's super basic, but to me, this is where my early version of myself used to get lost. What am I asking specifically?
Where should 8 and 9 be? The incisal edge.
Incisal edge. Very good. So like Ryan said, it's the incisal edge position. It's not where the teeth are. Now what tends to happen is we get a little bit led astray when we're looking at teeth. This guy has long teeth. They're kind of square. What kind of influences does that have on our decision-making process at this point? None of that should matter. We are simply asking the question, where is the incisal edge? That's it. what tends to happen is we maybe have short teeth, and we say, well, their incisal edge is here, but they have short teeth, so we need to lengthen them. Well, you never answer the question, what should you do, until you establish the position of 8 and 9. If there's anything that I think Spear has done for the profession, it's that. And that sounds so simple. But when you look at LVI and other full mouth rehab institutions, I feel like they get this one wrong. They're not putting the teeth in the mouth where they need to be. They're focusing on the relationship of the upper and lower jaw first, and not the aesthetics first. Does anybody know what the acronym that is used in facially generated treatment planning from Spear? And I share this not because I'm a Spear aficionado by any stretch. I love what he brought to the profession. I think there's a lot of value there, but these are things you're going to hear in your profession. Anybody have?
I feel like I've heard it, I just can't think of it.
Yeah, I know the last one they put was airway. They did include airway as the last pillar.
So it used to be 4 letters, now it's 5. They did add airway. Yeah. Fortunately, they put airway first, but you're right in the fact it was a late addition. EFSB.
Yeah.
Aesthetics, function, structure, and biology. And we can go over that at some point. The point is, for decades, it was a focus on the aesthetics first. Let's get the incisal edge position right. Then, what's the next step?
Function.
So let's just say for...
Are you saying for setting teeth? Is that what you mean?
So we're treatment planning right now so that we know what we can do. Yes, we're setting teeth in the process of doing this. So I would say we are hypothetically setting teeth.
So then lip support maybe next?
I like it. I think it's a good question. This patient has 8 and 9, so I don't know how much we're going to be able to change their lip support without surgery. So I don't think it's wrong. If the patient's edentulous, then yes. We would have a wax rim, and we would alter that wax rim to account for lack of lip support or too much lip support. So we have incisal edge of 8 and 9. Let's say we're happy with that. I think they're a little long in his face. The teeth aren't necessarily long. That's the important thing. The incisal edge is too far incisal. Does everybody understand the distinction there? Because if I say they're long in the face, everybody's thinking, what is the length of his teeth? So I have to be a little bit better on how I'm articulating it. But let's just say we're happy with the incisal edge position of 8 and 9. What is the next question? Let's say this was a wax rim. We established the right position for 8 and 9 in an incisal and gingival direction. What's the next step?
Midline?
Yes, I don't think that's wrong. That could go now.
But you could also, you're looking from a sagittal direction. Did you put them in the right plane?
Yes.
Like too much lip support, too little?
Do we like his upper occlusal plane as it looks now? Obviously, pretending he has teeth in that edentulous space from 10 to 12.
Are you getting at like following the smile line? Is that?
Yes.
Okay.
All right, so let's go to, so upper occlusal plane is what I was thinking, which, like Elena said, has to do with his smile line. Can everybody get a pen and paper? Because I think this will change how you see your patients. Everybody grab a pen and paper and just write down one thing. look at 5 people's upper occlusal planes tomorrow and where they meet in relation to the corner of the mouth. If you don't do this, you're not going to hurt my feelings, but if you do it, I promise you, you're going to have a deeper understanding of how the teeth are actually in a frame. The frame is the face. We get so focused on the teeth themselves that we forget the fact that a beautiful painting with a shitty frame is just a beautiful painting in a shitty frame.
What do you want us to do? Are we doing it yet?
So intentionally look at 5 people's faces tomorrow from this angle and just ask the question, where does their their occlusal plane intersect with their lower lip? So let's just say that was his occlusal plane. I'm having trouble commanding this this tool. I thought I had full control over it, but it's not letting me do what I want to do. But this is an approximate occlusal plane of the patient. Maybe it goes back a little bit right here, but it intersects with his lip right here. So when the patient smiles, I guess I missed that part. When a patient smiles, where does their upper occlusal plane intersect with their lower lip? And you'll start to develop an eye for what this should look like. So that when you're doing wax rims, when you're doing diagnostics, it'll help you. Here, Christian and I looked at this photo and we said, we like where number 15 is. Reason being, this occlusal plane normally intersects with a point somewhere just below the corner of the mouth. Is everybody following me? If you don't get it, let me know so I can restate it.
Can I ask a stupid question?
Yeah, no stupid question.
When you're saying to draw a line on the occlusal plane, obviously based on the way that you just drew it, are you ignoring the anterior teeth always, just the posterior teeth? Is that what you're paying attention to, where it intersects, or?
I drew the line through his teeth here because I feel like that's a better place to put them. To answer your question, no, you include the anterior teeth.
Okay, so this is just because his anteriors have super erupted and we know we're going to move them up. I see.
Correct.
Okay.
So isn't it just like above like the wet dry line when they smile? Like it should be just like apical to that when they smile. Think up their lip.
One more time. So the incisal edges of the teeth should be just above the wet dry line?
Yes.
I like it.
Even like posteriorly, like you can think about like where the wet dry line is.
May I offer a variation to that?
Sure.
It's not so much the wet dry line. Their teeth shouldn't touch the lower lip at all.
Right.
Now, when they're functioning, they should intersect with the wet dry line. That's a dynamic movement. The smile photo is a static movement. When they're smiling, none of the teeth should really touch the lip. Now, as you go farther back, that obviously will change. But really from second premolar to first premolar to first premolar, you really shouldn't have anything touching there. There are times when I've delivered crowns and something didn't look right, and I relieved just a little bit of the incisal edge, and everything changed because their lip will interact with something if the teeth are too long and they're hitting that lip, regardless of whether it's on the wet dry line or not. All right. Oh, that's why I couldn't see it. I was zoomed in. All right, so we have the incisal edge position of 8 and 9. We then have the occlusal plane of the upper teeth. Now this guy has teeth, so how are we going to communicate to the lab where we want them to build the wax up? So we don't have the opportunity to use a wax rim here. What do we have?
You have the teeth.
Bingo. So we can tell the lab, please make the upper occlusal plane according to this line. What I've done in the past is I'll actually draw a line on the model.
Can you draw it right on their teeth and take a picture?
Absolutely. Yeah, that's a great idea. I don't know if I've actually done that, but I think that's actually the most efficient way to do it. Let me write that down. So draw digital upper occlusal plane on photo.
This is kind of off topic, but Regan and I talked a little bit about that because he has like a communicating to the lab for like immediate dentures.
Yeah.
Especially when they have like a lot of teeth left, you just using their teeth and drawing a line on their teeth at the occlusal plane that you're thinking.
Love it.
Would you need 3 points for that, Stalker? If I'm thinking about that right, they would need at least like 3 teeth, right?
Like a tripod.
Like a tripod, exactly.
I mean, I've just literally like drawn a line, like from like canine to canine, or like even, it's not like perfect, but it's a good, I think it's a good place to start.
3 points make a plane? The answer is yes. Or do what Ryan did. You draw it.
Draw a line.
You know, there's many ways of doing it, but minimum 3 points. All right, so now we have incisal edge position. We have the upper occlusal plane. We're not even thinking about the lower at this point. Again, if we go back to denture prosthetics, we're not thinking about the lower until we finalize the upper wax rim. This is no different here. So if we're going to have the lab do a wax up, what's the next thing we need to do? We've established incisal edge position of 8 and 9. We've given them the occlusal plane.
Like the angulation. Yeah.
Go ahead, Elena. So the angulation of what?
I was going to say like the buccal inclination of the teeth.
Absolutely. So oftentimes when we do a wax rim, I've talked to labs, that's one of the most under-adjusted parts of a wax rim is the buccal inclination. Where are we trying to get that buccal inclination? What information are we using? We've already talked about it.
What do you mean buccal inclination?
Lip support.
Well, we have lip support, which for a dentate patient is less relevant. The photo that Elena is referring to is this one here. See how retruded or retroclined these teeth are? That's determined by the bone of his maxilla, the pressure of his lips, and any dentistry that was done along the way. Well, if we're going to do an overhaul, we should ask the question, what axial inclination, axial meaning vertical, inclination in a buccolingual dimension do we want these teeth? Do we keep them where they are? Do we have the lab kick them back, or do we have them move them forward? To help us, we can remember that where it meets the gum tissue is somewhat fixed. So we really can't change that position, but we can change the incisal edge position, thereby changing the angle of the teeth. What's the anatomical landmark we're going to use to determine or to help us answer this? The wet dry line. So when we do an upper wax rim on a denture, we have the patient say 55, 55, because that's the phonetic that is producing the lip movements or the jaw movements that allow where the teeth are going to be in the upper arch to intersect with the lower to create the F sound, the fricatives. We kind of want to make sure that that incisal edge is landing on that wet dry line. Yes, we talked about that before, but we weren't necessarily there yet. We were talking more about incisival gingival dimension first, then the occlusal plane, and now we can go to the axial inclination.
Isn't that's dictated by like where the bone is too?
Yeah.
Right? I mean, that's like indentures. I mean, you're not going to throw it way off the,
Yeah.
That's why it's kind of confusing to me in some of these cases, because it's like this indentures, like the skeletal classification is really important when you're setting teeth and figuring out, how you're going to get your occlusion, or like, it's. I think it kind of dictates everything, and we don't really. Are we thinking about that yet?
I love what you just said, man. That's beautiful. We definitely should think about it. We often don't, we being the dental community, because it's so damn confusing to think about all of this stuff on top of all of the other things that we have to do. That's why I love treatment planning outside the confines of a busy day, because I can think through these things. You're right. Sometimes the bone isn't ideal, and that's when we have to ask the question, does this patient need bone moved so that we can get the results that we want? Now, what Spear does is he says, you put the teeth in the mouth from a diagnostic perspective where you want them, then you ask the question, how do you get there? So you definitely have good perspective in the fact that, yeah, it's not as easy as an edentulous patient, but even edentulous patients, I don't think treatment planning lends itself to answering that question well. Libby's not on the call tonight, but he could share with you one of the cases that him and I are working on. It's an all-on-4. Her bony situation was super difficult. She had seen a few other dentists. They made her some dentures. They did not go through anything remotely close to an exercise, and she was that 1 out of 20 patient that really needed some thought. And it was so bad that she literally couldn't even fit the dentures in her mouth because she had not so much bone, her maxilla bone was very anteriorly positioned. Premaxillary hypertrophy, there's all kinds of different terms for what that is. The point is, it made for a very difficult prosthetic solution. We want to know those things ahead of time. So, yeah, I mean, we got to know where the bone is. That's why I like taking CAT scans on everybody, because there are times when this particular photo will lead us down a road of like, okay, well, we're not going to be able to get the aesthetic result we want and the functional result that we want with the bone as it currently exists. So then we have to bring in tools like ortho or orthognathic surgery, or at least have those conversations with the patient. The whole point of this is to not go down a road, have a patient be pissed off at the end. They spend $35,000 and we tell them, well, you had too much bone. We got to tell them in the beginning, and it's going through a very thorough, methodical process that's going to allow us to uncover these things so that we can tell patients, I understand you don't want orthognathic surgery, but what you're giving up is perfection. So if perfection is what you want, we need to have a different conversation. So we took a little bit of a rabbit hole, but Ryan, I love what you said, because
Sorry.
No, dude, I'm telling you, that's worth this entire conversation, was that comment right there. So I'm glad we went down that road. So yes, the bone does matter. And there'll be cases when we have to ask the question, how do we resolve the fact that the bone's not in the right spot? Let's just say the bone's in the right spot for this guy. We like his incisal edge position. We've got his upper occlusal plane. Do we want to change the axial inclination of these teeth? I would say he lands on the wet dry line. His lip support is good. Now, lip support's hard to change in a dentate patient because we don't have any acrylic to support the lip. Now, how do we go about it if he didn't have good lip support and we wanted to address it? We can topic for another day. But this is the moment when we want to have that discussion. So we're happy with the axial inclination of 8 and 9. Christian had said the midline. Let's just say we're happy with the midline. This is the appointment at which we want to make sure that we get that. The axial inclination of the midline. If we draw a line it looks a little bit canted to the left. Then again, he has a nose that's deviated to the left. His head is positioned to the left. But let's just say we're happy with 8 and 9. We've already treatment planned this case, so we don't necessarily need to go down that road. What is the next thing we need to ask? So we've done our wax rim. Let's just say we're doing an upper denture. We send it to the lab. What information do they need now? They know where to put the teeth, but they don't know what teeth to select. So what kind of questions can we ask to start giving us some guidance on tooth shape? We're not at shade yet.
Ask the patient if they like the shape of their teeth.
Yeah, getting a sense of what beauty's in the eye of the beholder. Getting a sense of what they want is super important. We have a program called Preview. Maybe we'll go over that next week. It's essentially a digital smile treatment planning software. Did we use that, Christian, on this guy? Greenbaum and I used it on Christine Cook. Regan used it on Kristen Snow. I forget her name, Kristen. Yeah, Stone, sorry.
Stone, yes, Stone.
Zach, you want to talk a little bit about maybe not your experience with Kristen, but using...
Yeah, because that's been freaking terrible. You want to talk about the aesthetic interview?
Yeah, go for it.
Yeah, so in treatment planning in this case, the patient was like... She came in with an extensive history of dental issues, which resulted in, I'd say 80% of her teeth being borderline non-restorable. Like many of them were, I mean, we're talking heroic measures. So she wants to save everything she can, and she has something coming up. So she comes in to get like an MIFL on number 8. Great, I can do an MIFL with the best of them. So she comes in, I got her in the chair. 4 hours later, she's still not happy with her MIFL number 8. So I realized this was going to be a highly demanding patient. So in our discussions, and after setting the expectations very clearly with her, that what she might have in her head isn't what's possible for reality, we had an aesthetic interview where I printed out the majority of the facial photos, the side profile, like the main smile photo, the repose photo. I printed them out, and then I sat with her in the consult room, and we talked about what she liked in each picture and what she didn't like, and what was important to her. And what came out of it was that the most important part of her smile was the small gap between, like the step between 8 and 7. That was like the most important thing in her entire mouth, like black and blue caries. But that was her smile to her. So in kind of going through that process, I mean, I was almost nauseous when it came to prep day. But when we delivered her temps, she was over the moon. I mean, it was unbelievable.
Yeah, I can't wait for your 10,000-foot view recanting of this case.
Yeah.
Just patient with thoughts in their mind that are different than what reality is always the challenge that we have. But the reason I wanted to bring it up, and this is where her temporaries, which obviously look great compared to where she was, we had used Preview to do a smile mock-up with her, and we'll go over that. Preview is a great software. But let's let's finish on, we're just doing the upper wax rim for Vinny. We tell the lab where to put the teeth. Or sorry, yeah, where to put the teeth. The incisal edge, the occlusal plane, the axial inclination of 8 and 9. Then we select the tooth size. But here's the challenge. What if we put in teeth? Let's say his upper gum is right here, but we want to put in the size teeth that he has now. We have to have the conversation. How do we get there? So if the patient has square teeth, but their incisal edge position is accurate, what are the solutions for us to get more real estate to make properly sized teeth? And obviously having these conversations early on is important. So having the lab make a wax up is easy, but if you tell the lab to make a wax up and you tell them to go over the stone model, you probably will have wanted to have the conversation with the patient. Are you okay with A, B, C, or D? So what are the 4 solutions that we could provide to the patient to get longer teeth when we don't want to lengthen them incisally? So we have one direction to go. It's gingivally. What are our options?
Crown lengthening.
So crown lengthening would be the, well, I don't say the easiest, but most obvious.
Gingivectomy?
Gingivectomy. What's that?
Intrusion.
Intrusion, orthodontic intrusion. If we did orthodontic intrusion, and let's say we were happy with the incisal edge of 8 and 9 and we did orthodontic intrusion, what do we also have to do?
Then we have to move the incisal edge back down.
Right, which I'd imagine is true for all of these cases, but it's always good to know what are all of the steps involved when we make a decision. So perio, ortho, surgical, we can actually move the maxilla. Obviously that's not something many people are going to do, but it is an option. Implants would fall under the surgical realm. And then removable. Obviously that would be significant here. So once we get all of that information to the lab, we can say, all right, not only do you put the incisal edge here, but you need to put the cervical edge here. So you have to tell the lab exactly where to put the cervical edge for the teeth. If you don't, they're only going to use the current cervical margins. Crown lengthening in the posterior is something I like doing a lot. I hate this kind of gumminess. These are implants, so we don't have that option per se. But there are a lot of people with natural teeth where this shows, and it's pretty easy to do some crown lengthening in this area if you're going to be crowning the teeth anyways and get a very stable long-term result. So let's fast forward to where he's at now. Labani, you did a bang-up job here. We'll talk about what he did on the lower, but this was the first comprehensive appointment where he reduced or did the preparations on all of the teeth. What happened here? Christian, you and I haven't talked about this, and you did nothing wrong, but this is something that has happened to me, and I wanted the opportunity to talk about it quickly. We only have 2 minutes, so I'm going to make it quick. Does anybody have any idea what happened there? That's not iatrogenic.
I mean, I think you're getting at the fact that we did a bone graft procedure, a ridge augmentation on 9 or 10, 11, and we added so much. And when I sutured, I think I had sutured the tissue more apical, or it just kind of healed that way, and thus 9 appears shorter than 8.
We're going to run out of time, but let's revisit this next week. I just want to show you that's the PA of the tooth. When you laid your releasing incision here, he had no bone supporting that tissue anyways. So that was likely to happen regardless. You would have pat cord, that might have happened. Better it happen under your guidance.
What does he mean? I mean, is that tooth even worth keeping? There's not much.
There's lots of conversations we can have about all of that.
Okay.
I just wanted, when you are looking at periapical films, always get a sense of where their bone level is and where their gum tissue is.
Nick, can you check the other picture real quick too? The prep photo. I think that's important. Yeah.
Now the prep photo is after the surgery, so you can see the pins that are here. Christian did a very nice job with the ridge augmentation. Most likely, the releasing incision was right here, so that we got a full flap. I don't recall if that was it, but that's most likely what led to it. This guy had bone loss. That's why that happened, not because of any reason other than this was bound to happen anyways. Nature was already heading down that road. Now the question is this gingival asymmetry something we care about? No, the patient doesn't care about it. At the end of the day, this is more about structural integrity. I do think that with proper occlusion, this tooth is fine. This guy had been banging on that tooth, and that's probably why he had some bone loss. But with a proper makeup, this should be fine. If not, then we'll go down that road. All right, we're going to end it short. Thank you, everybody. We will see you next week.